and welcome back to Health Watch. We've been talking about some common shoulder disorders, and we left it. We were talking about rotator cuffs, and I just want to mention, as I thought about you are suturing back to a tendon that has some disease in it. So I think that was, one of the issues, whether or not what's the stability of that. And the second part is, it would seem to be that the sooner you do the surgery, where there isn't a lot of destruction of that tendon, would be better than later.
Yeah,
so
you're absolutely right, Vince, and that's certainly been one of the things that we've changed in our approach to rotator cuff treatment. Rather than see somebody with a small tear and see how they did for a while before deciding to operate on it, we're definitely better getting to these things sooner, because the healing potential goes down as the tear gets older, the tissue gets to be poor quality, and even if you get a decent repair on it, it may not necessarily heal. You could end up going through all this and having a poor result. So it's definitely better to repair these early. The healing potential is much better, and we've been very satisfied with the results.
Really? Yeah. These are done. Can they be done arthroscopic?
They are. Yeah, I think most of the ones that we do are done arthroscopically.
Yeah.
Sometimes we'll still do an open procedure, or if we find some other pathology, a biceps tear or something that might need to be repaired through a mini open technique.
And again, the process afterwards is still a 4 to 6 month process.
It's a long process, and that's where the frustration comes with the patient. They don't like the immobilizer, and they want to start using the arm before they're ready. They're starting to feel good, and they want to start lifting, but you really can't. It takes 12 weeks for early healing of that tendon to the bone. It takes 4 to 6 months for solid healing.
Yeah.
So,
and you appreciate what you have to do with your arm, so I think it's worthwhile doing.
Yes.
All right, let's talk about some other issues. Particularly arthritis. We all have experienced that. Certainly, I have of joints. I don't normally think of arthritis as a shoulder joint, although maybe I should now at this point. But what are some of the common things you see with arthritic patients that are more diagnostic?
Well, most of the arthritis patients will present with pain. They usually have had discomfort for quite a long time, and it's been gradually getting worse. Usually they'll notice some loss of range of motion also. There may or may not have been some sort of trauma in the past. Many of these just develop spontaneously, although sometimes it's related to maybe sports, football injuries, and certainly in some of our younger patients we'll see, particularly in powerlifters, who are really overstressing the cartilage. And although most of the patients with degenerative arthritis present to us in their 50s, 60s, 70s, a lot of these patients come in even in their 30s or 40s with significant degenerative arthritis, which becomes a much more difficult problem.
Now, you talked about diagnostic studies. Will a plain film be more likely to show that?
Usually does, yes.
Okay.
Many times if there's arthritis, we don't really need an MRI scan to make any further diagnostic evaluation of the arthritis. But if we're thinking about surgery, then we would either need an MRI or a CAT scan, because we want to see what the socket looks like to see whether or not that's reconstructible.
Okay. So it's gotten to a point where, I'm thinking it's like hip surgery, knee surgery, doc, just keep me up all night. I really can't move my shoulder anymore. What do you got to offer? Yeah.
Well, again, most of the time we would try a non-surgical approach first. Physical therapy, maybe cortisone injection, which might give some temporary relief. It's usually not long-lasting. Anti-inflammatory or over-the-counter analgesics. And if those things don't work and the symptoms are significant, then typically we would do a joint replacement. Younger patient, we might try maybe an arthroscopic debridement if their arthritis isn't too bad. But once it gets significant, then we're looking at replacing the joint surfaces. We do total hip and total knee replacements. People are familiar with that. Total shoulders can also be done, though, and can be extremely successful.
It's been fairly recent, hasn't it? I mean,
yeah, they've actually been around for quite a while.
Really? You don't see as much of that.
It's just not as common.
As shoulder or knees and hips.
Yeah, there's been development in shoulder replacement just as there has been in hip and knee.
It's a ball socket joint, so you figure you should be able to do that. Yeah.
Right. So what we typically would do is, if this is a normal humerus bone, we would remove the head, and then we have this implant that goes down into the canal of the bone, and the metal ball comes in a variety of sizes, as does the stem, and these are then fit into place to replace the ball.
Not unlike what hip surgery would be.
Correct.
Right.
And this particularly duplicates the anatomy that's already there. We can also replace the socket We have these are fairly small plastic pieces. These are, we make some drill holes into the bone and cement that into place so that then we have a smooth surface against a smooth surface. And we have another material that has an ingrowth metal, which instead of using cement, this can be placed into the bone and then the bone grows into it. Now, in order for a total shoulder replacement to work well, you need a good rotator cuff tendon. Unfortunately, some patients don't have a good rotator cuff. If they have a small tear, we may be able to repair that at the same time that we do the replacement, but if they have a large chronically retracted tear, then this type of shoulder replacement will not work. So if the patient has very severe limitation of motion and severe arthritis, then we can do a different type of shoulder replacement, which is newer, and it's called a reverse shoulder replacement. It's called reverse because we put the ball on the socket and the socket on the ball. So when we remove the head of the humerus, we're putting this device in, and that you can see is the opposite. It's the socket, and then this part here goes into the original socket so that these two, again, can articulate. This does not rely on a rotator cuff tendon to make it function. The larger muscle that overlies this is called the deltoid, and this is placed in a way that it's tensioned very tight, so the deltoid is under tension, and that then allows the patient to elevate the arm. So for patients who have a minimally functional arm, this is a good operation. It does have limitations. You can't place the arm behind the back. That's one of the biggest problems.
Right.
Rotation is restricted, but it does allow for pretty good forward flexion and pretty good pain relief. The complication rate is a little bit higher than the standard total shoulder replacement, but I think the results are still good. But we are, at this time, reserving this for older patients who have lower functional demands.
Right, I would think. And the recovery period for this, I would assume, would be very similar to what we talked about before.
It is. They actually get better faster, I think, than rotator cuff repairs do.
Is that right? Really?
Yeah, because typically we'll just put them in an immobilizer for about 6 weeks and do a very limited motion program, and at 6 weeks we'll start them using the arm, and some of these come around actually pretty quickly.
Physical therapy?
Yeah. Yeah, they don't need as much physical therapy as a rotator cuff repair does.
Okay, fascinating. We got a break, but it's been great having you again, as always, Ray, and some of the newer advances techniques is quite remarkable. Thank you for coming.
Thanks, Vince.
And thank you for watching Health Watch.